Welcome, everyone. As I say, I'm presenting this on behalf of a couple of my HSMA course mates, Maddie Smith and Jon Green, looking at modelling the demand from 111 for primary care services. So about half of the sort of 19 million calls that are made to non-emergency 111 telephone service in England result in a primary care disposition. That is, either the patient is advised to contact their own GP or a request is made to a primary care service by 111 to contact the patient directly. However, there's been little change to commissioning arrangement for primary care to actually meet this kind of new demand from 111. And the concern is that if a timely service can't be provided to patients, actually they may seek alternatives themselves, such as calling 999 or attending the emergency departments directly. So the sort of two questions really we set out to address was, one, to see whether actually is it possible to create a model of the healthcare system as it relates to these callers, and if we can do that, then perhaps we could adjust reality and say, well, on the if we could make it so that callers always received a timely provision of primary care service, would that actually lead to a reduction in avoidable emergency department attendance? And Dan touched on some of these operational research methods, but essentially we use two of them. We use network analysis and we use discrete event simulation to help us do that. We also are fortunate that the Yorkshire Ambulance Service have been not only run the 111 service for Yorkshire and Humber, but also have been contributing data to the Connected Yorkshire dataset, which comprises of over 1 million patients in Bradford and the surrounding area, and essentially is linked ambulance service data, 111 data, and primary care data sets together, which kind of makes it more straightforward, certainly won't say easy, to actually follow patients as they sort of transit through the healthcare system. And we were interested in what happened to them in the 72 hours following that initial 111 call. So the first step to a discrete event simulation is actually to get a pen and paper out and actually create the model on a piece of paper by engaging with stakeholders and people who really understand the system, as well as just doing some preliminary data analysis to actually kind of try and spot the patterns and define the kind of relationships between these systems. And that obviously was quite challenging because we didn't really understand the data that well. And it turns out, while there are relatively few components in this particular model, they can all interact with each other in two ways, which made it actually slightly more problematic than we anticipated. But some of the early work we did meant that we could actually generate process maps. You've seen some of these already, where actually we could see patients. Each one of these dots is essentially a patient who's called 111 and been given a primary care disposition. And over here is that's the index. It's IUC, which is the integrated urgent care, which I'm using synonymously with the 111 telephone service at YAS. Over here is GPs, which is where everyone should be transiting in theory. But actually, we're seeing that trickles of patients are coming out of 111 and going to 999 or going to their local emergency department, for example. So already at quite a high level, we had an indication that actually patients are transiting in different ways than perhaps is anticipated. They're also, in some cases, spending quite considerable time in that system, rotating between different healthcare systems. And bear in mind, this is literally only a 72-hour period. The other issue we had was actually really, while the model is fancy pants, SymPy, coded in Python, and there's been lots of blood, sweat, and tears, for consumers of this data, they're not really that bothered. And we needed to find a way by which we could communicate our findings in a way that those who are not necessarily technically qualified could actually understand the data. And so in order to sort of start that journey, we developed a dashboard, which essentially is just a web page, but behind the scenes is powered by Python. And so the user can actually specify how they want the model to run, and then they can actually look at the results themselves. So I'll just briefly just show you that now. This is effectively it. At the moment, it's quite basic in terms of the configuration. You can specify when the simulation should start, how long the simulation should run for, and the number of runs. So because the kind of model underpinning this is based on sort of distributions of data, which are then randomly sampled from, you can hopefully capture some of that kind of stochastic random nature of the real world in the model. but it helps to actually run the model multiple times and then kind of aggregate the data to get a more accurate picture of what's going on. And then the other advantage of discrete event simulation, of course, is that we can actually suspend reality and we can ask what if questions. What if we changed how the system worked and did something else? And in this case, our what if scenario was, what if actually every caller who came in to 111 with a primary care disposition actually did have a timely contact with the GP? So some of the preliminary results, and this is sort of really much, this is very early stages still, actually looked at comparing the real connected Yorkshire data with the model data. And we can see actually in terms of the total numbers, it's fairly close. The model is currently overestimating the number of callers that are coming into the system. But in terms of the kind of first low hanging fruit, which is actually what is the first activity that a patient's receive, or which part of the healthcare system do patients access after that initial call, we can see they match pretty closely to the real data. And the first thing that obviously really leaps out is that over half of these patients do not have any healthcare system access within 72 hours following a triage disposition of, contact or speak to a primary care service. In order to get to this point, we actually had to undertake a network analysis to really map the relationships between these various healthcare systems and how patients can transit between them. And what we see here in comparison to perhaps some other network analysis is that this is a two-way process. Patients can go from the index 111 call, represented here by index IUC. They can go to 999. They can't come back to that index call, but they can certainly call 111 again, or they can go to the emergency department and then come back to their GP, or perhaps come back to 111. And so network analysis is really useful when we were capturing this to enable us to estimate those kind of the probabilities that if you were at an emergency department now, that your next step might be to go back to your GP or call 111, or actually just exit the simulation because those 3 days had expired. But for an individual patient, we really kind of wanted to sequentially track their journey through the model. And the way we did that, just visually anyway, was using a Sankey diagram. So on the left-hand side, we have that kind of index 111 call. We can see quite a healthy number here, just exit the model, i.e. they do not have contact with any healthcare system. But as we have a look through here, quite a few patients actually do have multiple points of access of the healthcare system. If we look at this column here, for example, that's suffixed with a 5, that means that these patients in this group have had 5 healthcare system interactions. Bear in mind, this is in 72 hours. And while it is a minority of cases, that still represents around 2,000 individual patients. And obviously, there are a handful who get into double figures, who spend 3 days literally going from pillar to post. And so there's some interesting work around actually determining why that might be occurring. So this is back to the real data. So there are a little over 71,000 index 111 calls. And as I kind of pointed out before, over half of those actually just disappeared. They vanished. They were nowhere to be seen in 72 hours, which either meant they did not or could not access the healthcare service. We did see just under 2% of patients who went straight to 999 as the first action, and just under 5% of cases where they presented at the emergency department as their first healthcare service interaction. With respect to those kind of avoidable attendances in the emergency department, what we saw from the basic model is that actually it would appear that if you have timely contact with a GP, then actually there's a slightly higher percentage of cases that will end up with an avoidable attendance, 14% versus 11%. When we then looked at that kind of altered reality, when we only considered patients who, that we considered all patients who received timely contact with a GP. Obviously, the avoidable attendance rate was exactly the same, but it did generate additional attendances. And actually, while this says 6,600, this is actually 3 runs of the model. So if we assume that each run the same, in reality, we're talking around 2,200 extra attendances as a result of contacting a GP. Now, at this stage, I should stress, it's not entirely sure whether that is actually the case because the model still needs some work to refine, but it's quite an interesting and maybe slightly counterintuitive or unexpected result if that is true. So the next step for the project is to continue to refine the model. There's still some work to done to kind of validate the model on, you know, the real world as it happens now, before we can have a little bit more confidence in tweaking and adjusting reality when we ask those kind of what if questions. We're also looking to further develop the dashboard to allow more sort of granular control over the model itself, including potentially enabling an end user to actually upload their own distributions for patterns of arrival, you know, to call 111, maybe adjusting the transition probabilities to hopefully make this model more generalizable and generally more useful outside of this kind of initial quite small regional setting. With respect to the impact, I think this tool is going to be able to provide insight both for commissioners and other stakeholders regarding the kind of sufficiency of the current primary care service provision to meet this kind of flood of 111 calls, as well as highlight kind of just, you know, actually how patients transit through the healthcare system or don't transit through the healthcare system. It also is going to provide a springboard to demonstrate the utility for discrete event simulation and other operational research methods to actually harness, you know, the huge swathe of data that we have sitting in our data warehouse. And actually, we have a lot of pressing operational problems with no real clear solution. And I think operational research methods can really help provide some guidance for those kind of decision makings in what are really wicked problems. So in conclusion then, you know, modeling the patient healthcare journey with respect to this particular cohort of patients, entirely possible, definitely non-trivial and not for the faint-hearted. For those of you on the HMSA 5 program, I'd certainly advise you think about your data early and make a plan, you know, because actually this proved to be, took a very long time to kind of actually understand, figure out, and sort of coerce into a format that was actually useful. And the other thing, which I say is really tentative, grain of salt kind of stuff, is that actually if the primary care disposition timeframes were met, actually ED attendance would go up, although the avoidable attendance rates would be unaffected. Thank you.